What's up, everybody? So welcome to my video presentation. This is Andrew and Ruger. They're going to be my audience tonight, and Andrew's going to videotape for me. This is my evidence-based practice presentation. My topic is nursing engagement and patient safety. My research question was, in the hospital setting, could increase nurse engagement and patient safety policy compared to current practices of administrative oversight improve patient safety and outcomes? So how does this relate to nursing, you might ask? Patient safety is a nursing priority. It's also one of the foundational components of Maslow's hierarchy of needs. A study performed by the Workforce Engagement Advisory Board found that 60% of the 76,419 nurses surveyed felt disengaged in the workplace. A study from the Department of Health and Human Services stated that, according to Kootenai-Lee, 2016, when nurses are involved in institutional decision-making, nurses are less likely to report poor quality of care and patient safety, poor confidence in patients' ability to manage their care following discharge, and unresponsive hospital management when patient care problems are raised. So by encouraging and increasing nurse engagement in shared governments, we could help hospitals avoid penalties and maximize reimbursements for providing quality care. So I chose this topic personally because I believe that patient safety is a priority, and also it's a foundational component of Maslow's hierarchy of needs. Everybody has to have safety in order to move up in the pyramid. And as a traveling LPN, I've kind of seen a lack of engagement in some of the facilities that I've been to, and I see that not only does it lead to burnout, like Michelle is talking about, but also just poor patient care, poor patient outcomes, like lack of staffing, lack of communication, all sorts of things could go wrong. And you often see a lot of pressure ulcers and falls and skin tears and a lot of things that could be prevented. According to Biddison et al. 2015, they examined the association between employee engagement and safety culture over time. According to Biddison 2015, theories of high reliability and resilience suggest that organizations that are able to achieve high levels of reliably safe performance do so in part through shared norms of vigilance, willingness to speak up regarding concerns or creative ideas, a unified learning orientation, and shared motivation continuously seek opportunities to improve. Employee engagement is defined as positive work-related mindset. Engaged employees feel dedicated to their work. According to Biddison, feelings of engagement are associated with important worker outcomes in healthcare, including staff turnover, productivity, and patient safety events. The goal of this study was to examine the relationship between employee engagement and staff perceptions of patient safety. Specifically, is there a relationship between group-level measures of engagement and perceptions of patient safety culture, and does this association persist over time? The study hypothesizes that the degree of engagement in a specific work area correlates with the respective team members' perception of safety culture in that work area. A secondary data analysis was used to determine the relationship between the employee engagement and safety culture. 2,000 plus eligible staff members at more than 50 inpatient hospitals in the United States academic health system participated in this study. All inpatient units included in the study were located in the northeastern United States. The study examined the relationship over the course of 5 years, conducting surveys every 2 years. Surveys were conducted in 2009, 2011, and 2013. A total of 58 units and 2,722 staff participated in 2009. 61 units and 2,646 staff in 2011, and 59 units and 3,020 staff in 2013, according to Biddison 2015. The Safety Attitudes Questionnaire, or SAQ, developed by Johns Hopkins Hospital and the Gallup Q were utilized during this study. The surveys were conducted through both electronic and paper-based methods. Responses remained anonymous. Results were submitted to the respective unit leadership. More than 60% of the unit staff had to respond in order for the unit to be scored. SAQ responses were scored on a 5-point Likert scale ranging from strongly disagree to strongly agree. Neutral scores were omitted from this study. The SAQ contained a total of 4 domains and 12 items to evaluate employee engagement. Domains included teamwork, climate safety, perceptions of hospital management, and perceptions of unit management, according to Biddison. The median engagement survey response rates within the 3 time periods were 64%, 66%, and 72%, respectively, according to Biddison. Spearman's rank correlation coefficients were used to evaluate the association between unit-level engagement and safety perception scores. Only correlations of 0.4 or higher were considered, as this value was chosen to reflect a moderate effect size according to Biddison. Results suggested consistent relationships between safety climate, which focuses on perceived norms related to communication, learning, and error management, and engagement items reflecting, number 1, the clarity of goals and expectations, 2, opportunities for employee development and constructive feedback, and 3, supervisory support. Teamwork climate, which focuses on team relationships and resolution of conflict, was also consistently associated with perceptions of voice, that one's opinion and input is meaningfully counted. The authors declared limitations regarding data collection using 2 separate surveys. Data was noted to be minimally different from the inclusion criteria. The percentage of surveys collected via paper or electronic submission also varied during each time and interval. The study did not utilize the Bonferroni style correction model to reduce type 1 errors. P-values less than 0.001 were considered in this study, although values less than 0.05 are usually significant. The data may also be limited by staffing levels and inability to account for varying patient acuity in the units. Overall, these results support conceptual arguments that there is an association between patient safety and work environments that motivate and engage employees, according to Biddison 2015. Carthen 2019 study looks at the association of nurse engagement and nurse staffing on patient safety. The purpose of this study was to examine whether nurses' assessments of patient safety differ under varying levels of nurse engagement and staffing. A secondary analysis of cross-linked data was used to evaluate survey data. Data was collected from the 2007 American Hospital Association Annual Survey of Hospitals and the 2006-2007 Penn Multi-State Nursing Care and Patient Safety Survey. States involved included California, Florida, New Jersey, and Pennsylvania. The data to be cross-examined consisted of responses from 26,960 nurses and from 599 hospitals across the same 4 states, according to Carthen 2019. Nurses were selected randomly from the state boards of nursing lists of RNs for these states. According to Carthen 2019, this study had a 39% response rate. Hospitals with less than 10 responses were eliminated from the study. Guided by the Donabedian conceptual model of healthcare quality, which focuses on 3 components that influence quality care: structure, process, and outcomes. Structure in this study was represented by nurse staffing and engagement and facility affairs. Outcomes were represented by indicators of patient safety. Primary variables included nurse engagement and hospital affairs, patient-to-nurse staffing ratios, and nurse reports on patient safety, according to Carthen 2019. Independent variables were staffing and engagement, patient safety grade, and 7 indicators of hospital safety climate served as the dependent variables in this study. Engagement was rated using a Gutman scale based on 3 questions from the Practice Environment Scale of the Nursing Work Index. This allowed researchers to group hospitals into 4 categories: most, moderately, somewhat, and least engaged, based on median engagement scores from the nurses in each hospital, according to Carthen 2019. Staffing was averaged based on the ratio of patients to nurses during each nurse's last shift worked. Patient safety was rated using 8 questions selected from the Agency for Healthcare Research and Quality's Hospital Survey on Patient Safety Culture. A dichotomous key was utilized to assign a letter rating of A through F to each facility based on these results. Additional questions analyzed whether or not nurses felt that facilities held mistakes against them, if patient information was lost during handoffs, if they felt free to question authority, whether feedback was given based on incident reports, and if patient safety is deemed a management priority, according to Carthen 2019. These questions were answered using a 5-point scale of strongly agree, agree, neutral, disagree, and strongly disagree. Covariates included the use of ICU nurse responses as a control against the responses of medical surgical nurses due to differences in staffing. Other covariates included hospital size, urban-rural location, teaching status, technology status, and state. The average hospital in this study was medium-sized, non-teaching, low technology, located in an urban area, and a medium bed size, according to Carthen 2019. Nurses reported caring for an average of 5 to 6 patients. 32% of nurses gave their practice settings an unfavorable patient safety grade, according to Carthen 2019. Only 16% of nurse respondents strongly agreed that administrators demonstrated the safety as a top priority. 27% reportedly did not receive feedback after the implementation of changes due to incident reports. 41% of nurses believe administration holds mistakes against them. According to the study, each additional patient per nurse was associated with an increase in the odds of a hospital receiving an unfavorable patient safety grade by a factor of 1.06 or an increase of 6%. Additionally, for each unit of increase in engagement, the hospital's unfavorable patient safety grade decreases by a factor of 29%. The study indicates that engaged nurses were 35% less likely to report failure of administration to prioritize patient safety. Kootenai-Lee 2016 examines the relationship between nurse engagement and shared governance and patient and nurse outcomes to better understand the relationship. The study was based on the survey data from 3 sources. A secondary analysis of cross-linked data was used to evaluate survey data. According to Kootenai-Lee 2016, data was collected from the 2007 American Hospital Association Annual Survey of Hospitals, Hospital Consumer Assessment and Healthcare Providers and System Survey from October 2006, June 2007, and 2006-2007 Penn Multi-State Nursing Care and Patient Safety Survey. Survey participants were selected from the state boards of nursing RN licensure lists in California, New Jersey, Florida, and Pennsylvania. Survey results were collected via mail. The sample consisted of 20,674 registered nurses working in 425 acute care hospitals. Nurses included in the sample were involved in direct patient care. Hospitals were eliminated from the study if there were less than 10 respondents. Hospitals also had to participate in the HCAHPS survey and have structural characteristics reported in the 2007 AHA annual survey, according to Kootenai-Lee. The primary independent variable for this study was engagement and shared governance. This variable was evaluated using 3 questions from the Practice Environment Scale of the Nursing Work Index. Hospitals were grouped based on the median engagement score assigned by nurses. Other variables included nurse burnout, intent to leave the job within 1 year, job satisfaction, quality of care, unit safety, and confidence in management. Burnout was measured using the emotional exhaustion subscale of the Maslow Burnout Inventory, according to Kootenai-Lee 2016. A 4-point Likert scale was used to measure job dissatisfaction, quality of care, and confidence in management. Unit safety was evaluated using a 5-point scale. Additional covariates included demographic characteristics, employment information, primary unit type, and nurse-to-patient ratios. Patient variables were derived from the Hospital Consumer Assessment of Healthcare Providers and Systems Survey, otherwise known as the HCAHPS survey. These items included overall rating of the hospital and likelihood that the patient would recommend the hospital to family and friends. Additional patient variables included communication with nurses, pain management, communication regarding medications, and staff responsiveness. Hospital characteristics were obtained from the AHA annual survey. These characteristics included state, population density, size, teaching status, technology status, ownership. Magnet status was also utilized and obtained from the ANCC website, according to Kootenai-Lee 2016. Only 42% of hospitals were classified as having most engaged nurses. These hospitals were found to have significantly lower to nurse-to-patient ratios than their least engaged counterparts. These hospitals did not differ significantly in size. Hospitals with nurses who were most engaged and had a significantly higher percentage of favorable patient responses on the HCAHPS surveys. These patients were also more likely to recommend facilities with most engaged nurses to family and friends by a factor of 14%, according to Kootenai-Lee 2016. Least engaged nurses were 43% more likely to report dissatisfaction with their jobs, 52% more likely to report burnout, and 24% more likely to leave their current employer within 1 year. Findings were similar in least engaged nurses regarding quality of care ratings. Least engaged nurses were 33% more likely to rate quality of care as fair or poor, and patient ability to manage care after discharge, and 77% more likely to report that management will not resolve problems in patient care. Aiken 2017 discusses hospital nurse staffing and patient outcomes. According to the article, the United States Institute of Medicine published a study in 1999 estimating that medical errors in the U.S. were among the top 5 leading causes of death. The World Health Organization took action by forming the World Alliance for Patient Safety shortly after. The Center for Health Outcomes and Policy Research then undertook research at the University of Pennsylvania to determine if variation of RN staffing in hospitals contributed to poor patient outcomes. Research is occurring on an international basis across 30 countries, including Chile. This study summarizes key findings of this research program referred to as RN Forecast, according to Aiken 2017. Patient outcomes and mortality rates were found to vary substantially across hospitals in previous studies. Nurse ratios also varied across hospitals in every country. In England, the average patient-to-nurse ratios for all hospitals was 8.6, but varied 5.6 patients per nurse to 11.5 patients per nurse. 2 systematic reviews examined for this study have provided evidence that better nurse-to-staffing ratios lowers patient and mortality rates. According to Aiken 2017, we found that every 10% increase in the proportion of professional nurses among all nursing care personnel at the bedside was associated with 11% lower odds of mortality after general surgery and 10% lower odds of poor hospital ratings from patients. The RN Forecast study is conducted using survey data collected from registered nurses. Nurses are selected randomly from each participating country's registries. Nurses may work in private or public general hospitals. The survey is based on the PES NWI as well as the Maslach Burnout Inventory. HCAHPS patient surveys are utilized to derive variables regarding the hospital size, ownership, teaching status, technology status, and rural-urban location. The goal of the study is to determine the influence of nurse skill mix, staffing, and work environment on patient outcomes. Variables studied included mortality, failure to rescue, patient satisfaction, readmission, length of stay, as well as nurse satisfaction and burnout. If I were to conduct my own study, I would examine staff nurse involvement in patient safety policy and the effects on patient outcomes. The study would be based upon Cantor's theory for structural empowerment. I would conduct a longitudinal study with a duration of 5 years to better understand the impact of increased staff nurse involvement in policy decision and patient outcomes. I hypothesize that patient outcomes will be significantly better at facilities where RNs report being most engaged. The sample would include both rural and urban hospitals across Kansas with a minimum of 5 nurse respondents. Hospital inclusion criteria would require that facilities have participated in the Agency for Healthcare Research and Quality's 2018 Hospital Survey, and as well as Kansas Hospital Association's QHI program and monthly utilization review. Quarterly surveys would be conducted to evaluate patient safety and outcomes. Nursing staff engagement and safety policy and job dissatisfaction rates would also be evaluated quarterly. Nurses would be selected from eligible facilities based off of current Kansas State Board of Nursing RN registries and the facility nursing staff rosters. The independent variable for this study would be nurse engagement based on a 4-point Likert scale ranging from most, moderately, somewhat, and least engaged. Nurses who are most engaged would actively participate in policy decisions. Nurses who serve on hospital governance and policy committees would be considered moderately engaged. Nurses who serve on nursing committees would be considered somewhat engaged, and nurses who state these opportunities are not available to them would be considered least engaged. Job satisfaction would be evaluated on a 5-point scale as well. Outcomes would be evaluated quarterly based on KHAI's QIH and monthly utilization reports. Outcomes would also include successful discharge without readmission, readmission within 30 days, and hospital-acquired infection rates, medication errors, falls, witnessed and unwitnessed, and failure to rescue, as well as patient mortality. So this is my poster. So here I have the business implications of engagement and safety. So it talks about like the cost of increasing nursing positions proportional to the cost of patient care due to adverse outcomes, as well as the results for, if you have an increased patient load, how that affects readmission rates. And here I have the Donabedian model, Cantor's theory of structural empowerment, my research question, how it relates, as well as my study. I also have Cantor's theory of structural empowerment up here, and Maslow's hierarchy is listed as well in my studies, and my references in the bottom corner.